there are centers of excellence for sure who are very good at doing their training in a structured way, and others is more ad hoc, where people feel the interest, want to do something and take that interest, which I do like as well.
Mm-hmm. Mm-hmm. Oh, that makes sense.
Now, where is my record? Is it okay if I record this session?
Yeah, of course.
Cool. Are you going to PAS?
Yes.
Oh,
Will I
cool.
see you there?
Yeah, I'll come there too.
Yeah.
We initially wanted to do another sort of septic shock session, but it wasn't accepted, which was a pity. But
yeah. You never know with these things.
No.
This time I don't have any like pre-conference or anything that I'm participating. Just I have one small research presentation, and that's it.
And I'm always surprised they sort of pop up, those meetings, while you are there.
Yeah.
All right, people are coming in. I'm going to record and start our introduction. So welcome everybody to another session of the Australian Neonatal Lectures. Today it is my great pleasure to introduce to you Dr. Adrianne Bischoff. She's a neonatologist, from what I got originally from Brazil, but moved to Iowa and has been there now since 2019 as part of their faculty. And you can just notice that faculty has been certainly world leaders in creating, performing, and structuring neonatal hemodynamics in not only its understanding, but also in its training. And Adrianne wrote a beautiful paper about this, and I asked her to, give us a presentation. How do you do that? So Adrianne, over to you.
Okay, let's make sure that this is working. Can you see the slides appropriately?
Yeah, excellent. Thank you.
All right. Thank you, Kurt, for inviting me and for sharing some of our perspective. And what I want to do today is tell you a story, not about ECHO itself, but about how we changed the way that we think about cardiovascular care in neonatology. Because we didn't just add ECHO, but we fundamentally, I believe that we changed how we do our decisions in the NICU. So let me start with a baby that we've probably all of us have taken care of in some sort of similar shape and form. This was a male baby born at 27 weeks by a C-section. Birth weight was 900 grams. The baby presented with hypoxemic respiratory failure, requiring transition to what we used here, which is high-frequency jet ventilation. You can see there the X-ray. The baby's needing a fair bit of oxygen, 65%. For those of you who know ECHO, you can see a sweep of the suprasternal view with a PDA that is quite large in size and is left to right, as you can see on the pulse wave Doppler on the right side. And so based on this information and with only the things that I've just shown you, a simple ECHO evaluation, first of all, I think it's important to recognize that this is a kind of baby that would have been eligible for enrollment in some of the most modern PDA trials. So here I put some of the inclusion criteria for example, Benedictus and baby Oscar. And you can see that this baby would have easily been enrolled as long as he didn't have any of the other major exclusion criteria for the studies. However, when we go a little bit deeper in the history of this baby, I didn't put all the pictures here, but the baby had normal indices of right ventricular performance. But what you're seeing there on the picture is the pulmonary artery Doppler. And you can see that the VTI from that image is quite small. And when we calculated a right ventricular output, which was hard to do given the image that we got and the results, it was extremely low at 28 cc's per kilo per minute. And when we look at some other parameters of this echo, there are some features of elevated pulmonary artery pressures, including a right to left transatrial shunt and a TR jet that I don't have the number, but you can see that the peak velocity is approaching 4 meters per second, which means that the pulmonary pressures are quite elevated. So ultimately, what we are seeing in this case is not really a PDA problem, but it's actually pulmonary vascular physiology, where the PDA is actually supporting the cardiac output, and in which, therefore, if you randomized this baby for PDA treatment, you could have actually harmed him. Just so you know kind of what happened to this patient, we gave this baby 5 parts of nitric. You can see that even within the same day, a couple of hours later, you can see a little bit of the duct in the picture below, but the transatrial communication is now probably mostly left to right, perhaps bidirectional, but definitely predominantly left to right. The right ventricular output is now much, much more robust at 106 cc's per kilo per minute. And then 24 hours later, on this nitric of 5, our conclusion of our assessment was that now this baby has a moderate PDA with low to moderate volume shunt. When we proceeded to the following day, that shunt had continued to progress, even though the baby had been weaned off inhaled nitric oxide. We started the baby on some Tylenol. The baby got extubated on day of life 3. And by day of life 5, the PDA had a small PDA, low volume shunt that no longer was significant, no longer was treated, never needed any sort of intervention for the remainder of the infant's admission. So this just goes to show that once we treated the physiology, not the number, the baby actually improved. And if you had gone through a very simplistic assessment, you might have had the incorrect answer. Now, here we have another case. This baby is a 4-day-old, 23-weeker, and you can see that the baby's FiO2 and ventilator requirements are getting progressively worse. What happens is that the team empirically decided to start this baby on inhaled nitric oxide, which is at this time point that I'm showing you here with the arrow. And what happened is that the baby actually got worse, needed an increase in mean airway pressure, increase in FiO2, and had worsening lung fields on the X-ray. So the next day when we came in and we heard about the story, we scanned this baby and we saw a large PDA that was 2 millimeters, which was large for this size of baby. There was pulsatile left to right flow, and the estimated QP to QS was almost 4-to-1. One could argue that obviously this scan was done after a therapy had been given. So yeah, I agree, we can't know for sure how it was before. But the combination of these kind of pretty dramatic features of PDA physiology on top of a clinical worsening with the initiation of nitric definitely raised the suspicion that the underlying physiology was flow-driven and not PVR-driven. And the baby got worse with nitric, not because nitric is always wrong, but because the physiology was actually being misunderstood at the bedside. So this is one of the issues that we have in modern neonatology, is not that there's a lack of therapy, but it's that we're often treating the wrong thing. This is how we frequently practice, rightfully or not. We react to the numbers and not the physiology. So hypotension gets treated, with fluid or inotropes. If it's refractory, I apologize that the words are missing, but you would go for a different kind of agent. If the baby has hypoxemia, you increase the mean airway pressure, you add nitric. But the real question is, what are we actually treating? And very oftentimes we don't really know, which is why I got into this specialty and into the wants and needs of neonatal hemodynamics in the first place, because I'm a type A personality that really, really wanted to have more precision and know with more information what was going on to my patients. So we've reduced complex physiology to rules, as for example, the old mean blood pressure equals gestational age. But if you know the origin of this concept, and I'm sure many of you are aware, but it was actually quite imprecise and somehow became dogmatic in neonatology. And while all of this might be easy to remember, it's actually pretty meaningless when we think of it in biological terms. And a lot of your colleagues' works with Nick Evans and Martin Klukow there have shown this for many, many years. And I know that everyone is well educated in this concept. And then again, this is a slide that I made it intentionally busy because the reality is that there's multiple interactions, multiple pathways, and yet we often apply a one-size-fits-all therapy. And that's where harm happens, because when we do a symptom-based approach without comprehensively understanding and assessing the cardiovascular physiology, we can choose ineffective therapies that have a potential for harm if we use them in the wrong circumstance. And even when we do use echo, this is the model that was traditionally happening, at least here in the United States or in Canada, which is where I trained for the majority of my career, where there's a disconnect, there's a delay, there's limited physiology information, and it was never really designed for real-time decision-making, right? So here you had a question that was being posed by us at the bedside. The ultrasound then comes and is done by a tech, that then goes to an echo lab and gets interpreted by a cardiologist in a dark room that has no real connection to what is going on with the patient at the bedside. And that you might request an echo 6 hours later because you have now instituted a therapy, and you might get the answer of, well, I told you 6 hours ago that it was pulmonary hypertension. Why are you even asking me for another scan? When for us, we are now facing a baby that is completely different, and that we want to see if our therapies have changed anything and if there's something else that we need to be doing, right? So there's a paradigm shift, and what has changed is that TN-echo or targeted neonatal or neonatal hemodynamics, or however you want to call this, it's not a tool, but it's a shift in how we think. So if you think about kind of the three domains, you have cardiology, you have an anatomy-based assessment, but there's kind of a historical lack of mechanistic insight. You have cardiac focus that gives you kind of binary answers in a more broadly available tool, but that has a lot of limitations and has a risk of flawed understanding of the overall hemodynamic state. And I'll show you some examples of that. And then you have neonatal hemodynamics, which is kind of what we are going for, which is about integrating physiology in real time to guide the therapies that we are using for the patients. So obviously this didn't happen overnight. You can see this is a timeline that we included in the manuscript that Kurt was alluding to. And obviously there were a lot of early adapters, particularly there in your side of the world. And then we kind of moved toward kind of Canada and the structured programs that started there. And then eventually in 2019, the United States finally implemented kind of a consultation model. 2019, the first formal TN-echo fellowship training in the US was launched, and I was actually the first fellow of that program. And since then, we've continued to make a lot of progress and continue to try to expand and train more and more people, which takes time, but it is possible, and it is the correct way to do it. And the difference is not about the technology only, right? It's about the structure and how we are doing this. This is obviously a very rapidly growing field. We have representation in some kind of major organizations. There's a significant boom in peer-reviewed publications done by neonatologists that are interested in this kind of domain. So this is being applied not only at the clinical side, but also academically, and leading a lot of initiatives and physiological thinking and bringing back a lot of physiology-based management to the bedside, which I believe is extremely important in neonatology. So let's talk a little bit about kind of a little more on the spectrum of evaluations that you have. And I think it's important that we clarify roles, because this is not a competition, but it's a spectrum, and it's about understanding what is the role of each of these different modalities. POCUS, like I said, is a fast binary tool that has some roles, but that are quite limited in terms of cardiac assessment. There's TN-echo, which is a structured physiology, hemodynamics assessment, and that gets incorporated into a hemodynamic consultation, where then there's a full integration of both the echo features with the clinical features and a very good understanding and expertise about how to manage the baby's cardiovascular system, almost in the same sense that a cardiac ICU would do with their congenital heart disease patients, where they have ICU intensivist experience as well as deep knowledge of physiology and pharmacology. So the mistake that happens is when we use one of these tools when another one of them is actually needed. So this was a study published a few years ago that that suggested the use of POCUS, for example, for the crashing neonate. And obviously there's benefits to this, but there's also some challenges. And one of the things that we kind of did not agree as part of this publication was the use of cardiac POCUS, for example, for pulmonary vasodilation therapy and consultation experts. So currently under our North American targeted neonatal echo guidelines that are supported the American Society of Echo, we do not agree with this fully in the extent to which was being presented in this publication, for example. So let me show you an example of how, if you oversimplify and you limit an assessment, you can actually cause harm. I was actually involved with this patient a couple of years ago. This was an 8-day-old, 39-weeker myelomeningocele. The baby was post-op day 4 from the myelomeningocele repair, had been well in room air, feeding by mouth. And then on that day 8, started having some tachypnea, worsening metabolic acidosis. The team appropriately escalated care, did a septic workup, started antibiotics. The baby continued to look unwell, was now mottled, pale, had a significant increase in lactic acidosis, had escalated from room air to now needing CPAP and 50% oxygen. And at that point in time, we were consulted, and the team was inquiring what's the differential diagnosis. And this is the first picture that we got, which is an apical 4-chamber view. And you don't need to be an expert in echo to notice that there's significant systolic dysfunction, primarily of the left ventricle. The right ventricle seems to be affected to some extent as well, but the LV is essentially not doing anything in this picture. And here is the parasternal long axis. I've labeled the structures in case people are not fully aware of the views. But again, you can see that there's very little function of the left heart and the myocardium. And again, here is a parasternal short axis. And again, you can see that the contractility is clearly impaired. However, here's what we get when you complete the assessment, when you don't stop just to do a quick function check. And this baby had a critical coarctation of the aorta. The duct had closed, and you can see that there's a significant narrowing, and this baby ended up needing prostaglandin and so on and so forth. So obviously this is a one-off case, but if people forget that this kind of situation can happen, and you are not good at getting arch pictures and ruling out congenital heart disease and doing comprehensive assessment, you might miss some diseases, and you might treat with things that are potentially not only not going to help or not going to help to the full extent, but could also harm the baby if you choose the wrong therapies. So the new targeted neonatal echo guidelines by the American Society of Echo dictated the POCUS has a role in the following circumstances. If you have a suspected pericardial effusion or tamponade, that is absolutely indicated. If there's evaluation of kind of global cardiac function and filling in an acute cardiovascular collapse, meaning you have a baby that suddenly is completely unwell, you are in a kind of near code situation, you put the probe on the chest to say, is the heart empty? Is the heart moving to some extent or not? Yes or no? It's a very crude, good function, bad function that anyone can kind of appreciate. And then the last indication of cardiac cardiac POCUS, kind of, is for umbilical venous catheter and any central line placement, which we kind of tend to, say that it's simple, it's just for line placement. But I actually find it that in real life, it's one of the skills that takes the longest for people to learn. So let's go for another case. This one was also one that I was involved when I was younger faculty. This is a 4-day-old, 28-weeker, 1.3 kilos. This was a twin-to-twin recipient twin that had been intubated and was relatively well on a mean air pressure of 8 in 21%. And you can see there the acute collapse of this baby as we were rolling in the unit at 8 in the morning. Baby was starting to have bradycardia events. The nurses were bagging at the bedside. The SATs were in the 80s, even though the baby was being bagged to 100%. They did an x-ray. The tube was in good placement. The baby then proceeded to become very hypotensive. And so what's the differential diagnosis? We put the probe on the chest, and it became pretty obvious right away that the baby had a significant effusion with tamponade. This was a UVC that appeared actually well placed if you looked on x-ray, but it was deep when we did our assessment. So the baby had a pericardiocentesis, the line was adjusted, and the baby proceeded with a relatively unremarkable NICU course after this event. So this is the kind of role where cardiac POCUS is absolutely well indicated and useful, and we definitely advocate for it. So TN Echo allows for repeated multi-parametric assessments with an in-depth physiology context. And it's not a snapshot, it's a trajectory. So here's a little bit of the continuum of what hemodynamics consult and targeted neonatal should be, the role for cardiac POCUS, and then what should be kind of a universal skill that hopefully most neonatologists have the ability to do, or at least should be aiming to have as an overall skill. Here's another case. Here's a 2-day-old. Sorry, I have a lot of cases because I think showing in real life how this can be used and what's right and what's wrong is quite helpful and tends to resonate with people. But so here's a 2-day-old, 30-weeker that presented with hypoxemic respiratory failure. The baby is in 75% of oxygen even after surfactant administration. You can see from this initial view that there's the heart is moving pretty well, even without any quantitative assessment, but the right side structures, especially the right atrium, look pretty dilated and pretty large. If you see, let me see if this will play. This is a parasternal short axis. I'm sorry that if it's not playing continuously, but you can see again, the left ventricle is on the bottom, the right ventricle is on the top. So you can see that there's significant RV dilatation. And then we have a tricuspid jet that estimates a pulmonary artery pressure of 33. The PDA is bidirectional. So what's the differential diagnosis? Is this pulmonary hypertension? Should we be giving nitric oxide to this kind of baby? Again, I promise I'm not going to be boring and just present you with coarctation cases, but this was a baby that we identified a posterior shelf and did have a coarc, was not presenting in an acute collapse because it was not a critical coarct. The duct was still fairly patent, but you can see that if you didn't do all of the images and if you didn't do all of the steps to rule out more important problems, you could easily have been fooled to say this is an acute pulmonary hypertension or a PPHN case, and you could have given nitric to this baby, which would be absolutely the wrong thing to do. So what is the endpoint? What is a hemodynamic consultation? It is about integration. It's about longitudinal care. It's about providing a recommendation. It's not just about imaging, but it's about clinical decision-making. So we start with a clinical review of the patient, clinical status, medical history, any investigations that are relevant to the case, any treatments that the baby's on. We perform a standardized targeted neonatal echo evaluation, meaning that every single baby that gets an echo gets the same imaging protocol, irrespective of the indication, because we don't want to have biases. We don't want to go thinking, oh, this is a pulmonary hypertension screen, therefore I should be checking these images. It doesn't matter. We should be checking the same exact parameters in every single echo, because I can tell you a gazillion of examples that I would have been fooled if I had skipped some of the evaluation. And then finally, we provide a medical recommendation. We are consultants. We provide the medical team with a diagnostic impression with thoughtful integration of both the clinical and the echo information. And then we provide a plan for what therapies to do or not, and how to provide longitudinal follow-up for the patient. In terms of the consultations and how they are done, they can either be symptom-based or they can be disease-based indications. So here are some of the examples. There are babies that get automatic scans in our unit depending on their underlying disease. For example, babies with hypoxic ischemic encephalopathy that are undergoing cooling immediately get a targeted neonatal echo on their first day of admission in order to tease out their hemodynamic status and triage for particularly subclinical right ventricular dysfunction, which we know has been associated with adverse neurological outcomes. And then we have obviously the more classic ones, which are symptom-based, right? The baby is hypoxemic. The clinical team wants to know, is this the heart? Is this the lung? Should I give nitric? Should I give something else? And so on and so forth. Let's do another case of targeted neonatal echo in action. This is a 30-weeker born by an emergency C-section because of placental abruption. Mom had been using some fun drugs. Apgar scores were a little bit low. The baby had had 4 intubation attempts, was also hypoxemic, initially on 65% oxygen after surfactant. And then overnight, the baby progressed to needing higher oxygen. And now the saturations are in the mid-80s preductally, in the 70s postductally. Here you have the apical 4-chamber view. I'm not going to interpret for you. I'm just going to keep it as a surprise and keep going. It's not as easy as the other ones, right? This is not quite as slam dunk as the other ones. I find it that just looking at this, my eyeball is not good enough. I want to have some more quantitative assessment of how the function and the performance of both sides of the heart is. I have a TAPSE, which is a marker of RV longitudinal function, which was 3.2, which is low for a baby at this gestational age. Here you have the parasternal long axis, apologies. And here you have an M mode, also estimating the fractional shortening of the LV to be 23%, which caveats apart is indicative that there's some LV dysfunction as well. So bottom line, we see a baby that has biventricular dysfunction and who is in 100% of oxygen. So actually, instead of giving nitric oxide to this baby, what we recommended was to treat the heart dysfunction first. And this is an echo that was done just a couple of hours later after the baby having gotten epinephrine and Mironone. And even by the eyeballing, you can already see that the heart is a lot more snappy, that that free wall of the right ventricle is moving a lot more up and down. And when we redid the fractional shortening, it was much improved than a couple of hours earlier. So the question is, does this actually matter, right? Does it actually change anything? And this is a study, I have a couple of them that I'm going to show some examples, but this is a study that seems a little bit outdated, but I still think it's quite important, where they looked at their experience in Toronto when the program was kind of in the early phases of the sick kids group. And what they found was that T and echo resulted in a change of management in 41% of the consultations. And it also resulted in better adjudication, for example, of PDA, and it led to less PDA ligation referrals because there was better understanding of significance of those ducts. So it's not really just about seeing more, but it's about deciding better. This is another very important study that we are quite proud of here, where we looked at the impact of establishing an early hemodynamic screening in our extremely preterm population, where in Iowa, every baby born at less than 27 weeks gets a targeted neonatal echo in the first 12 to 24 hours of life, sometimes earlier if they're sick, but at the latest at 24 hours of life. And what you can see are the trends in both kind of epochs. One is before hemodynamics was implemented, and one is after the establishment of our program. And what you can see is that the odds of the composite of death or severe IVH increased by about 1% per year in the earlier epoch, but then decreased by 41% per year in the hemodynamic screening epoch, which just reflects a new and more rapid increase in survival free of severe IVH after hemodynamic screening was introduced. If you look here on this figure, you can see that survival free of severe morbidity also increased. The incidence of ventilator dependence at 36 weeks was lower. The incidence of NEC, which was already extremely low at 6%, further declined to 1%. The overall rate of medical therapy for PDA was higher in our epoch, but the need for definitive PDA closure was decreased, and there was also a reduced incidence of death in the first postnatal week. And I think it's important to know, I didn't put all the results because we don't have enough time, but this is in the setting of an already high-performing center. Iowa was already in the top charts for survival and good outcomes in these extremely premature babies. And this is also despite the fact that the modern cohort was comprised of younger babies that were smaller in size and that had more maternal morbidities. So even though there were historical changes in time, which we tried to adjust in kind of this complicated graph that one of our statisticians did, even with that, there were, as you can see, very significant changes in our outcomes. This is another study, because I don't want to focus just in Iowa. This is a Canadian study comparing TN-echo versus non-TN-echo approach in sick preterm neonates who had an acute critical illness. It's quite big. They had 622 patients, and about half of them received TN-echo guided care, which meant TN-echo within 12 hours of any treatment initiation. And what you can see here is that TN-echo was associated with lower mortality, lower episode-related mortality, and lower death, or at least grade 3 IVH. So even in this kind of slightly different population, it clearly improved how we were taking care of these patients. And then I wanted to highlight that this is not just a North American phenomenon. This is a Spanish study of over 300 babies, preterm babies, 131 of them who had early TN-echo for screening of low systemic blood flow. And what they found was that exposure to an early echo screening was associated with a significant reduction in grade 2 or more IVH or early death. This is the paper that Kurt was alluding to, and this is a very extensive table that I by no means expect you to be able to read any of these letters, but it summarizes all the papers that Angelica and Patrick and I could find that examined the impact of neonatal hemodynamics and targeted neonatal echo in different scenarios. So you can see that I'm not just cherry picking the cool 2 or 3 or 4 papers, but this is actually being more and more reported in the literature, and some of them are quite interesting. So I recommend that you take a look. So moving forward, besides my opinion that this does change, is how do you actually do this? How do you build a program? And there are a couple of pillars that we focus on. One is obviously the clinical care, the consultation model with real-time assessment and recommendations. There's a very important focus on education, not only of our trainees that are learning to scan and how to be consultants, but also the interdisciplinary collaboration with allied health professionals. So we've done a lot of education with our colleagues from nursing, nurse practitioners, physician assistants, respiratory therapists, bedside nurses, but also with other specialties. So it's not uncommon that any specialties that do come to the NICU, that we provide some conferences or education for, palliative care, pulmonology, even the surgical group, and so on and so forth. There's obviously a big pillar that is important for us, which is about research, about maintaining that inquiry, a lot of research that is imaging based with both clinical and translation applications, because we want to keep learning. We want to keep finding out what's normal, what matters, what changes. And as a kind of a future, not really my domain, but I guess I would be remiss to not mention that AI is coming. Multimodality monitoring is important. We do have members of our team that are working with sick bay kind of platforms where we have minute by minute signals, physiologic signals, and advanced fancy analysis looking at predictive analytics and how to combine that with targeted neonatal echo information as well. So if you were to start this, how do you do, right? We always suggest that for people that leave our program and that are going to try to initiate this somewhere else, that they start small. You come to Iowa, there's 9 faculty of us. We have a 24/7 service. We have a very well-established consultation model. You can't really replicate that right away. So people have to start small, choose a niche, and then build it from there. You have to build consensus and have collaborators, especially within the cardiology group. For us, it is very important to have a partner in our echo lab where we can bounce off questions, where we can, have their support if we have any questions about anatomy or about interpretation of the results. We do monthly educational sessions with our colleagues in cardiology and their trainees. And so that multidisciplinary, multi-specialty approach is also very important. And then communication, as much as it sounds kind of woo-woo, is absolutely paramount because we have to be able to document what we're seeing. We have to have systems in place for how to maintain our images in the medical records so that we can protect ourselves legally, which is a big deal here in the United States, but either way should be a big deal anywhere. We have to be able to communicate well with our colleagues. I focus a lot with our trainees on kind of the art of being a consultant within your own specialty, because you have to choose your battles. You have to know your audience. You have to come across as, I'm here with a new tool and I have things and more information that you didn't have before. And I'm here to help you so that we can all make the baby better. And this is what I would suggest. And then bounce back ideas and accept and meet people where they're at, such that you are teaching and empowering them to make decisions, understanding that this is new information for the entire team. And you have to kind of work that ladder and not just, come in hot, which sometimes people do. We have to choose the right tools. We always recommend that people have a machine of your own with your software, your own computer, your hard drive, your contracts, et cetera, et cetera. I'm not going to bore you with any of that. And you have to maintain some key components to keep your program thriving. The obvious one is training and education, having a curriculum that focuses obviously a lot on physiology, pharmacology, and learning how to scan, but also learning how to interpret the literature and how to teach other people. You have to have all the technology and equipment stuff well set up, and we have our numbers ready to go whenever we run into issues. And then again, I'm going to focus and be a little bit repetitive, but have the support and collaboration with other teams, not just pediatric cardiology, but people in your own division, and also the technology people that keep the operations flowing. So this is what it looks like. In Iowa, we have an integrated hemodynamics fellowship, which is a 1-year fellowship after NICU training. We do have some time that our trainees spend in the pediatric echo lab, but the majority of the learning skills of how to scan are done in the NICU setting, and our trainees progress kind of on a weight basis because we have very good relationship with our nursing team, and we want to make sure that the babies are not getting cold, they're not being bothered for too long. So there's competencies that the trainees need to acquire in order to move down the ladder of weight or of sickness of the baby. We obviously go through the physics of ultrasound imaging, but a lot of the focus is on physiology, disease, and pharmacotherapeutics as well. And here you can see some pictures of our room and how we are always busy and drawing on the board and asking questions and so on and so forth. In general, our trainees, by the end of that 1 year, have performed at least 400 to 500 consultations and complete targeted neonatal echo scans. I would say that I think last year our trainees ended up with 600 on average, each of them. So it is very heavy. And just as a frame of reference, when we ask our pediatric cardiology trainees over their 3-year fellowship, the average number of scans that they end up doing is 150. So in 1 year, we are getting more than 3 times the volume of those. And it's not just about volume in terms of learning how to scan, but really understanding the nuances of each patient and how to treat them. And if you ask most of our trainees at the end of that year, if they're happy and comfortable and ready to roll and take over the world, a lot of them are still fearful because they have seen how challenging it can be, and they really rely on having the support of our team, even at a distance, to manage kind of more complicated cases and to continue that kind of lifelong learning experience that we promote. There's obviously limitations of this kind of consultation model, right? In many places, the access to 24/7 services is limited. There's a response time. We're not 24/7 in the hospital. We still have to be called in. So for the crashing neonate, we might not be there in a timely fashion. There's needs for, vascular access program in some places. That's not an issue, but in many units it is. And obviously what is brought up to us constantly is the lack that there's not enough training programs, and how can we keep up with the need for having more specialists presence in more unit if we are only training a kind of a handful of people every year, which is a limitation, but it will get better with time. So the question is no longer for me, does TN Echo help, but how do we make it accessible for every baby? So here's just thoughts that I decided to put on my cloud of things that I hope the future will hold, with machine learning, multi-center RCTs that integrate more physiology, global expansion, automation, data sets, individualized care, and so on and so forth. And with that, I end my presentation, and I hope that we can continue a discussion and answer any questions that you guys have. Thank you.
Oh, thanks, Adrianne. That was a very good overview of indeed the work you guys are doing. You started off with cases, which I think is great, that just illustrates that there are hemodynamic profiles, or as you call them and I call them too, they're physiological, pathophysiological profiles, and that can change, either due our treatment or just during the disease. You called that, we put this complex physiology and we put them into rules. I really like that statement. Then you started explaining the differences and the overlap between POCUS, TNE, and the hemodynamic consultation, again explained with cases, and which, lots of them you showed, the only way to know as a clinician what's going on is to put the ultrasound on the baby. But you can miss something if you're not putting enough depth and detail into your assessments. You showed all the literature and the whole list indeed, which we couldn't see, but all of them showed that this kind of approach leads to a change in management. And then you brought up, how to build a program. Let's say more in words, because, you've been doing this for what now? 2019. Now, how long is that? That's 7 years. To be honest, you have built a gold standard. But I have to giggle, probably everybody, 9, faculty members. Yeah, that's the kind of dreams we can all have, but probably not achieve anytime soon. But I do think what you have built is a gold standard. And what I think is really important, you highlighted the fact, after 400 and 500 scans, you can still have surprises. And you can still run into what is this, and I think that's important to realize as well. All right, well, let's go to some questions. There's one from Elizabeth Chong. Of the 500 hemodynamic consultations, are those single cases, or is there also sort of repeat in the same baby, which things change? What kind of things we have to think about?
We typically, the way that the fellows keep their log is by a complete echo. So the 80 to 100 images that is obtained as part of each individual assessment. So there might be a baby that has repeat reviews even within the same day or within a couple of days, but they perform at least 500 full complete scans during that year. But obviously they get involved in a lot more than that. We have two fellows each year. So we are doing, they are doing each their own 500, 600 consultations a year from start to end. But on a full year, we end up doing over 2,000 consultations in total. The majority of the babies get one echo a day, right? But then you have the every once in a while very sick patient that might have 2 or 3 assessments. I think the maximum I've done within a 24-hour period was 4. That's a good question. But the way that they log it is based on a full imaging scan. So the 80 to 100 images that we obtain.
And then can I cling on to that one? So on the second scan on the same baby and the initial physiology, you still do the 80 to 100 images the second time?
Yes. The exception is that the very first time that a baby gets scanned, there's a couple of extra images that are kind of mandatory from a congenital heart disease screening standpoint, like an arch-sightedness, a VSD sweep, make sure that the 4 pulmonary veins with individual Dopplers are connected to the left atrium, and so on and so forth. So those we don't repeat once you've delineated that the anatomy is fine. But all the other ones, yeah, we do. So the first scan may have 100, the second scan might have 80 images, but we do perform the exact same one. And there is some logic to that from a research standpoint, because every single echo we treat it as an opportunity for learning in the future in a very standardized fashion. So if you wanted to assess later on a cohort of babies that have gotten nitric oxide, you now have a pre and a post echo that have the exact same information for both of them. So that's why we continue to do the exact same protocol before and after. That's how we chose to do it. Do I think it's mandatory to be done that way? No, not necessarily. I think you can assess things in a more targeted fashion once you've excluded. But also the physiology changes, and I sometimes it is hard to, I should look at just the PDA and maybe a 4th chamber to see if the ductus direction has changed and see if the heart is squeezing better. That might work for 70% of the cases, but a lot of the times the new things appear that if you don't do the full comprehensive protocol, you might miss it as well.
Yeah. So. And maybe for the non-scanners, what's the average time it takes to do a scan?
So we aim to have that full scan in less than 20 minutes. Most of our trainees by the end of their year are doing it in about 15 minutes. The record in our group is 7 minutes.
Yeah. Look,
so we're fast, and we train people to be fast, but also to be accurate. So that's why the trainees initially start with, the 2-kilo baby and above, where they can be bothered for a little bit longer. Then they have to prove it to us that they are consistently scanning in less than 30 minutes to move on to the next weight block, and so on and so forth. So by the time that they get to the 500 grammer, that would probably get cold and bothered if they were spending too much time. They are already pretty competent at completing that scan in the kind of the 15-minute mark.
So Madhu has a question which is a bit broad, but it's about utilizing machine learning and AI integration. Are we anywhere? How far are we?
I think we're getting there. I don't think it's going to be as exciting as a lot of the things that we hope that it would be quickly, but there are people working within our unit in different ways. Like I said, there's some work being done with predictive modeling and the integration with kind of the multi-modality monitors that we have, but that takes time, and the analytics of that are quite complicated and take a lot of specific and dedicated personnel, which tends to be our main barrier. We have all sorts of ideas for how to use AI or predictive analytics, but we don't have enough people to be doing that kind of analysis. So I think that's one of the barriers, but I think it's coming. I think there's a lot of interest with it, and there's definitely people in different centers working with it.
Yeah, there's an interesting sort of presentation on the neonatal hemodynamics group where you can watch the videos on the YouTube channel, which I would agree it's starting, but we miss the people because Google taken them all and they're not working in hospitals. So, you know, it's hard to find the right people to do the AIs. I think this is an important point. There's overlap between T&E and POCUS, and even less than POCUS, which I'm also concerned about. But say POCUS, and POCUS includes lung, head, abdo, and some other sort of things which are relatively simple. Do you think, wouldn't it be better if instead of T&E, we call T and U? You know, targeted neonatal ultrasound, and we don't just do the heart, but we also do the rest. What do you think about that?
Yeah, no, I think that's fair. And in our unit, it becomes quite easy because we have different machines for the different purposes. And I sometimes, if I'm the attending or if I'm on call that night, I might choose the POCUS machine because it has the other probes for me to do the other assessments, where my echo machine, my GE, is quite bulky. It takes a little bit of time to warm up, and it comes with just the phase array probes. So but yeah, I think that that's relevant. But I will say that even as part of our T&Es, we do incorporate some stuff that would be technically part of POCUS. So for example, all of our preemies that we do that screening in the first 24 hours of life, they get a head ultrasound done by us as a screening as well. We want to see if they already have IVH. If they do, we will get a formal head ultrasound, but we kind of do a little bit of POCUS at that time. It's not uncommon that our T&E images will be spooled into our medical records with a bladder scan in the middle of them or something else. So there's a little bit of overlap, but I like what you said. I like that TNU. It's a good one. I might keep it.
Well, look, I would reflect that's sort of what's happening in Australia, probably a bit more, just like you're describing. Even the ones which are most interested in the heart would generally also reach out to the head and sometimes the bladder or whatever is required to get a better picture. I think lung ultrasound is certainly coming up in the various centers, and if you have a trainer into your center, certainly you should use that. Another question, another technical questions. Are you using matrix array probes and 3D images?
We are not at the moment. We are currently putting a small funding request to get a 3D probe, but we will get one of our 9 faculty to be kind of the champion of learning that with our cardiology colleagues, and then hopefully trying to incorporate as part of our protocol. But at the moment, we do not. The kind of technologies that we use outside of the standard pulse wave, continuous wave, color Doppler is tissue Doppler, strain imaging. And what we are starting to dip our feet a little bit is blood speckle imaging.
Yeah, these advanced modalities, although, you know, speckle tracking is not as advanced anymore, but still challenging in this small population. And I think the group who can teach you is very small. I think I can count them on, you know, maybe I need an extra pair of hands, but that's sort of what it is in the world. So you need to find your educators. But don't forget to reach out to your adult cardiology crews. An image is an image, and a technology is a technology that can certainly teach you or start teaching you if you're interested and feel more advanced in this particular thing. Maybe the last sort of words on, you know, lessons in training. You're like Spartacus, and you know everything has to be very specific. We're probably a bit more like, are you interested? And come join us. Let's do some scan and self-directed learning. Just what's your feelings and thoughts about it?
That's a hard question. I guess it has to start that way, right? If you don't have enough people interested, then you're never going to get a full curriculum and a dedicated program. Why would anyone spend another year of their life training and being paid less, which is the reality, if they could just become an attending? So somehow that's how it starts in many places. You find someone that can kind of mentor you in a more informal basis, and you try to tag along and learn as much as you can. But there's the downside of that lack of structure and the lack of of competency based, and who says you're good enough to now be using this independently or to take this to a different unit where you're going to be solo doing it. So pros and cons, you probably have to start one way, but eventually you have to go to a more structured kind of training, evaluation program, and so on and so forth.
I will try to find Spartacus here in Australia as well then at some point, but okay. No more questions in the chat box.
Iowa is quite cold, you know. Some of us don't like the cold. The Brazilians don't appreciate that very much.
Hey, thank you so much for staying up late and telling us about your story and how things are going in this particular field. And I can see indeed the future of neonatal hemodynamics, particularly in the understanding of the physiology and then asking the questions, why is things happening? And ultrasound is thus far the easiest and the best tool to visualize that for us. So I also hope that we get more and more trainees all over the world like little mushrooms, and we get more of that into our research, because that's still something, it's up to us to bring that data to the broader groups. Okay. Hey, thank you so much. And thanks to everybody for attending. I think we're back next week, but I'm not so sure. I'll double check that on you. All right. Thank you.
Thank you.